is that printer a color printer by any chance? I'm going to send you something if you don't mind. Thank you.
Let's see. All right, it is 12:02. We have a packed agenda today, so I'm going to go ahead and get started. Welcome to everyone for our April quarterly meeting for the Pediatric Readiness Recognition Program Community of Practice. I hope everybody is doing well, enjoying some nice spring weather. I know everyone is very, very busy, so I do appreciate you taking the time out of your crazy schedule to join us today to learn more about some updates with facility recognition and kind of some great information. We have a fabulous lineup of guest speakers today, panel discussion. Dr. Kate Remick is going to kick us off with a little background and overview. Dr. Hillary Hughes is here representing NEDARC and is going to give us some information around confidentiality of scores, really how we can use our scores in the verification process. And Dr. Mark Auerbach and Dr. Corey excuse me, I'm going to say your name wrong now, Corey, because I stumbled all over it. Chimpatazi are going. We're going to have a little panel discussion about some three very great projects, articles about ways to improve your pediatric readiness programs via evidence. So lots to come today. At this time, I'm going to turn it over right away to Dr. Remick. So take it away, Kate.
Great, thanks, Lisa, and welcome everyone. Thanks for joining today. Just by way of our standard acknowledgements, nothing that we're presenting today is the official views nor endorsement of HRSA HHS or U.S. government, though we are grateful for their support in helping us improve readiness. So next up. So before we jump in, this is really what we're going to be covering today. We'll talk a little bit about some lessons learned from the Facility Recognition Collaborative. And I know that there has been a lot of turnover of EMSC state partnership managers over the last 5 years. And some of you may not even know what the Facility Recognition Collaborative was or any of the resources that exist there. So I just want to do a little bit of level setting before we jump into some of the other key aspects of pediatric readiness recognition programs, and really spend some time directing you to some of the resources that exist there so that you can pull and peruse to your leisure. And then really just talking a little bit more about the community of practice and the intent and our growing evidence and how we got where we are. So with that, if you'll go to the next slide, please, Lisa. So this is really the purpose of what we are doing here. We are trying to increase engagement in pediatric readiness efforts, first and foremost, hopefully through the development of a pediatric readiness recognition program. And by doing so, that will allow us to expand our capacity to meet the emergency care needs of children. And as you all know, there's performance measures 4 and 5, speaking to both medical and trauma recognition. We'll talk a little bit about that, but hope to cover that in more detail over the course of the coming communities of practice. What's important to realize here is that this is absolutely a change in culture. Stroke, STEMI, and trauma centers have been around for decades now, and there's a lot of support to them, but there is not necessarily in every state and territory a lot of support for pediatric readiness or for pediatric recognition. And so the work that we are really doing is to change the culture within our state or territory in order to increase engagement in pediatric readiness efforts, and then in doing so, expanding our capacity to meet the emergency care needs of children. So I put this diagram up to really, emphasize the fact that this requires a lot of work to build that up and to transition that. And for those of you who are relatively new to the EMSC landscape, you can talk to, Evelyn, Morgan, Catherine, others who have been around for longer periods of time, and they will tell you that developing a pediatric readiness recognition program that's successful takes a significant amount of time. It takes relationship building, and you're not going to get there overnight. Next slide, please. So when it comes to thinking about your role with respect to this, you are really a pediatric emergency care coordinator. You are the pediatric champion at the state or territory level. And if you think about the work that we do with Everyday Readiness and thinking about growing the number of pediatric emergency care coordinators within EDs, translating their work in the front lines to the work that you're doing at the state level is really very analogous. You're trying to expand your reach and engagement among all of the other stakeholders within your state. You're trying to identify and build resources to help develop pediatric readiness efforts and activities and support pediatric readiness recognition programs. You share best practices with some of them. And then ultimately our work is to improve outcomes. So if we start at the higher level, the first piece is really just having influence or creating our reach, really making sure that people recognize us as EMSC State Partnership Program Managers as the pediatric champions within our state. Ideally, we don't have really any other competing priorities except to ensure that pediatric needs are integrated into our emergency care systems. And by definition, that means that we are the pediatric champions. And once we establish that reach and that influence, then we can begin to build up engagement, because now there's an understanding of why it's so important. And then that leads us to shifts in outcomes and eventually allows us to overcome disparities within our state or territory, which includes intersecting with more of the remote and rural areas within our state or territory to ensure that we're reaching them just as we are others. If you go to the next slide, please. So let's talk a little bit about our job. You know, if there were already financial incentives for hospitals to engage in pediatric readiness, then our job would be easy. And the point of our success, and I love this quote at the bottom, is that the definition of success is getting the things that money can buy, sure, but and all the things that money can't buy. And that's where your influence really comes to play here, is that our job is to not only convince hospitals that pediatric readiness is important, but that it's both achievable and worthwhile. And to get to that point, not only do we have to grow our voice or influence at the table of all the meetings and conferences that are happening across our state so that we are recognized as the pediatric champion, but we also have to be really strategic and ensure that our plan is taking the right steps along the way. There is, to this right, an image of the implementation checklist that we developed as part of the Facility Recognition Collaborative that launched in 2016. And throughout the course of these next few slides, you'll see a link to the EIC website where all of the Facility Recognition Collaborative resources can be found. It includes templates, it includes slides decks, it includes elevator pitches. There are a ton of resources that are there. Some of them may need to be a little bit updated or revised, and we'll talk a little bit about that. But please don't be shy in going to that site and perusing it to see how it might be able to help support you. You go to the next slide. So when we think about developing a plan, you know, anybody could say, you know, I have a PEDS recognition program, but if nobody actually joins or participates, then it's not meaningful. It brings no added value to the work that we're doing. So when we launched the Facility Recognition Collaborative, we all work together to say, what are the phases of implementation that we need to go through to get to having a very successful pediatric readiness recognition program? The first phase is really just understanding, what does my state look like? Where do changes happen? Where do cultural changes happen? Where does influence occur? And beginning to really research that to develop a core team to say, okay, so if I work through these steps, if I present to a regional advisory council, and then I present to a state advisory council, then I can grow my support for this work. And that's really what these first two phases are about, are identifying the potential leverage points. And there could be multiple different leverage points. It could be your state hospital association that's really interested in this work. It could be a state chapter of AAP or ENA that's really interested in this work, or ASAP. It could also be, for example, regional healthcare coalitions that are interested in this work. But there are many different possible leverage points that get you through phase 1 and phase 2. Phase 3 is a really, really critical phase. And the reason for this is that this is where we build consensus, we grow our influence, and we gather engagement. This is the point at time where we have to really have the elevator pitch that we're saying to all of these stakeholders, this is why PEDS readiness is important. This is why you can achieve it, or it's achievable within our state. And this is why it's worthwhile that we can actually improve outcomes for children. 4 and 5 are really a lot more about logistics. So we've already gotten our stakeholder engagement. They believe in PEDS Ready. They want to be involved in a pediatric readiness recognition program, but now we actually have to implement that. And so what are the key steps around that to ensure its sustainability? We all know that those of you who come from larger states, it can seem really challenging to even think about, how do I actually create a recognition program for hundreds of hospitals versus for maybe only like 10 hospitals in some of the smaller states. So just really thinking about the ways that we can be creative around our implementation for sustainability, and then moving into piloting and formal recognition. You go to the next slide, please. So currently, congratulations, Nebraska, we now have 18 states that have pediatric readiness recognition programs. Of these, there were approximately 7 states that existed before the Facility Recognition Collaborative. There were 14 states that joined the Facility Recognition Collaborative in 2016. And there have been a few other states that were in neither of those cohorts that have since developed pediatric readiness recognition programs. But what's true to all of these is that it takes a lot of time to really build up that influence, build up that engagement, and make this truly successful, where not only hospitals want to engage, but they have the ability to do so and are doing so. So next slide. So this comes from the saying that I'm sure some of you have heard: if you've seen one EMS system, you've seen one EMS system. Well, if you've seen one pediatric readiness recognition program, the same more or less holds true. When we kicked off these pediatric readiness recognition programs, even those that were started back in the mid 80s, hello, California, with the first EDAP program, and then in the 90s, Illinois and Tennessee, and then states since then, is that there wasn't a ton of evidence to say exactly what these programs should look like. And so when we started to really grow pediatric readiness recognition programs around the country, by definition, it resulted in a lot of heterogeneity, right? We had to work within the culture of these different stakeholder groups, because when you're changing a culture, whether you're changing the culture of an organization, or you're changing the culture of a nation, or you're changing the culture of a state, there are different drivers within each of those arenas. And so one size simply did not fit all. And when we came together for the Facility Recognition Collaborative, there were a lot of very, very strong opinions from key stakeholder groups to say, no, it must be single-tiered, or no, it must be multi-tiered, or it must involve this application process, or so on and so forth. And so you'll see that even though there are now 18 states that all have slightly different programs, it's because when we first kicked these off, there wasn't clear evidence to say this is exactly what these programs should look like. This is not dissimilar to when trauma systems started and when STEMI and stroke systems started, right? They didn't know what the criteria were initially going to be. And over time, more and more evidence has come out that now those criteria have continued to be refined over time. And we are in the same boat with pediatric readiness recognition programs. What I do want to clarify, though, is this issue around verification. So nearly every single state that has a pediatric readiness recognition program has not only an application process, but some kind of verification. And back in 2013, when we did some initial studies around, if you could click through to the animation, Lisa, when we did some initial studies and we looked at, well, if they're just excited about pediatric readiness, isn't that enough? If they just take the PEDS Ready assessment, isn't that going to get us to where we need to be? And what we found was that simply being aware of or participating in the pediatric readiness assessment did not mean that they were pediatric ready. If we did that for trauma systems, we would not have trauma systems that are meeting the criteria that we need today. And this holds true for pediatric readiness programs as well, is that we have to actually have a way of verifying that they have what they say they have. Otherwise, it may not be truly meaningful. If you go to the next slide, please. So the other piece that I want to add is that when we think about creating pediatric readiness recognition programs, every state has come up with their own language around it. And it's great, right? This is kind of the culture of, what we need to, and sorry, there's a quick question in the chat I'll address in just a second. There is this culture around getting our stakeholders engaged in pediatric readiness recognition programs. And so every state has also not only come up with their own program, but has come up with different terms and titles for how they recognize different sites. And these are just a few of those. What I would reflect on in looking at these names, and what you should reflect on as you're developing these pediatric readiness recognition programs, is how do these appear to families? Most families have no idea, as you all know, that one emergency department has any different capabilities from another emergency department. And when we start putting up decals or signage that says that they're pediatric capable or pediatric ready or they're child ready or any of these different naming conventions, that we hold a responsibility to really ensure that they indeed are. And so I would encourage you, as you're thinking about this, how we develop the naming convention so that it truly reflects the capacity and capabilities of those institutions with which we're recognizing. There was one question that came up about one of the territories maybe having a facility recognition that wasn't on the map, and we will look back into that and just make sure that we haven't missed someone. So thanks for that comment. If you go to the next slide, please. So before there was truly evidence to say these components of pediatric readiness are associated with improved outcomes, we instead said, okay, there's not really obvious score associated with improved outcomes, but we do know that pediatric readiness is common sense. And so we went through kind of work with our stakeholders to achieve consensus. And instead of focusing on, scores, we felt it was really important to focus on criteria that we knew impacted overall readiness. And again, you can find this document on the EIC website. This was a consensus document that was created during the Facility Recognition Collaborative of what should be the minimum criteria that every state consider using for their pediatric readiness recognition program. This is just showing domain 1 here. There's domains 2, 3, 4, 5, 6, 7, all included in this particular document. And I encourage you to go and look at that and peruse that and see what you can find relative to that and reflect on how those are represented in your pediatric readiness recognition program. We could not achieve a single overall consensus, but instead what we said was this represents a reasonable minimum criteria that is achievable and worthwhile for every participating site in every potential state that has a readiness recognition program. Go to the next slide. The other piece that I just want to highlight is, even though all of these pediatric readiness recognition programs are different in some ways, they obviously all have a single common thread, and that single common thread is that they reflect elements of the joint policy statement on pediatric readiness in emergency departments. However, as we think about all these different components of the guidelines, the assessment, and the score, they do not translate one-to-one. So if you look at the pediatric readiness joint policy statement, there are 7 domains that are listed, and there are really countless innumerable items that are referenced within that. It doesn't list bullet points. It provides a conceptual framework for the work that needs to be done in an ED to make it PEDS ready. When we created the National PEDS Ready Assessment, we had to whittle this down. And so instead, we really focused on what are the most critical items. This went through a national modified Delphi process to develop what are the items that need to be included in the readiness assessment. And instead of 7 domains, it really includes 6 domains, right? We took out support services because we felt that that was out of the authority or scope of the emergency department. And we whittled it down to less than 200 items. Technically, it's about 189 items, including some demographic variables and the like. Then the next piece is the score. So not all elements of those 200 items, as you know, are weighted equally. And what that means is that a score of 80 for one site may not have the exact same components as a score of 80 at another site. So you could have two hospitals that both have a score of 80 or 90. One of them has both PECs, the other one has none, and yet they have the same score. And this is why criteria can be extremely important, and that a score can be a nice, perhaps, entry point, but may not be the end all for what we should be using to recognize sites. So if you go to the next slide. So now I want to take some time to welcome Dr. Hillary Hughes, who you all know very well from NEDARC. And we're just going to talk through a few questions that seem to come up a lot from state partnership managers. And the first being just thinking about score validity. So, so using a score versus specific criteria for recognition. So I don't know, Hillary, do you mind just kind of sharing your thoughts, or what are the pros and cons around that?
Sure. And this is, I kind of pooled my NEDARC team just to think about the use of the score for recognition. And I would like to echo a lot of the things that Kate said, that when we think about score, it's variable what that score means. And the criteria are probably more important than the score, but there are pros to having the NPRP score, at least as a component of medical recognition. For one thing, it's easy to quantify, and we can stratify categories of score. So a lot of people will put them into a score of 90 or more, put you into a certain tier, a score of 75 to 90. And a lot of the research that we're going to hear about in a little bit is based on these different quartiles or categories of scores. It does help to establish a baseline of pediatric readiness, and it's something that can be used kind of across the board, which is nice. It does assess some important structural measures for each ED that we know are important to kind of ensure that fundamental pediatric readiness is there. We really like that there's a gap report, and this is a QI process that allows different hospitals and EDs to assess change over time and gives them the ability to improve their scores and then watch their improvement over time. And it's a way for us to compare hospitals across regions and states. We know there's a lot of differences, but this is one kind of common way that we can compare people. There is data linking scores to in the higher quartiles to improved outcomes, and you'll hear a little bit more about that here in a bit. And then the assessment is based on the guidelines of care for children in the ED, which, as we know, is jointly developed by the AAP, ACEP, and ENA. And so we feel that that partnership led to a very strong foundation for this assessment, and that's important. However, there are some cons as well. So when you look at the I think sometimes what gets lost in the message is that the NPRP assessment is really providing a baseline level of readiness. So 100 is really the baseline. That's the goal, is for everyone to have 100 so that you have everything you need fundamentally to be ready for a sick or injured pediatric patient. So if you think about it that way, anyone scoring less than 100 is not truly completely ready at that baseline level. The most important thing is that these are self-reported. These scores are self-reported by the ED nurse manager or whoever takes the assessment without verification in most cases. And as Kate kind of alluded to, they might not reflect some of the reality on the grounds. So having some type of process to verify this would be important. And then, although it assesses those structural components, things like having protocols and policies, it doesn't, the NPRP score doesn't tell us how often those protocols are actually used or revised or updated. And the assessment doesn't reflect any actual clinical care provided. So it doesn't get to the outcome that we want, which is what is the quality of care being provided to those children. And then lastly, the score only evaluates the ED. It doesn't reflect overall hospital readiness. And we know that the most critically injured or ill children are going to require ongoing care. And so although it gives us a good look, and we know how important, especially with some of Dr. Newgard's work, is for that initial care provided in terms of long-term mortality and outcome, it doesn't talk anything about what happens to those children after they're admitted. And speak up anytime if you guys have any questions about any of these pros or cons.
And feel free to add comments into the chat box too. So
All
right. Well, let's go to the next question. So thinking about confidentiality. So as everyone knows, when sites decide to take the NPRP assessment, they're guaranteed confidentiality. So just a few questions that have come up that we're hoping you might be able to share your thoughts on is, can a site share their score on a pediatric readiness application? Can that score be used as an entry point for pediatric readiness recognition? And are we allowed to recognize sites publicly on our website?
Right. This is something that we feel pretty strongly here at NEDARC. We try to protect confidentiality as much as possible. We recognize that this is not patient level data. We're not using PHI, but in all the assessments, we are using some PII. So we're taking names of our nurse managers and some of their contact information. And then we recognize that there is some reluctance within each state, especially if there's more than one children's hospital or people competing for patients, for scores to be publicly available. And so we've always asked our managers and everyone else involved in the program to not put up any score of one individual ED, and just to present things in aggregate to try to kind of protect some of that information. However, when we talk about recognition, I think this is different. So if this is a voluntary program in your state and a hospital elects to enter into this program, I think they're in some ways giving permission to have their score shared. And in part because I think they want to advertise that they are pediatric ready, that they have a higher score, and that they feel that they are capable and ready to take care of children. So I think that's an important thing to remember, is they're voluntary entering into this program in most states. We still wouldn't be necessarily sharing an individual score if they reach a level of recognition or verification, unless that's the only thing that the program is based on. And even then the score wouldn't necessarily be made public, so that shouldn't be too much of an issue. And then I think most hospitals, again, would be pretty happy to know that, or for people to know that they have likely a higher score because they are now pediatric recognized. So I don't think it's going to be a big issue to have these scores used in terms of confidentiality. We obviously would not be sharing things like our ED nurse manager information. And then, sorry guys, I don't know how to make this stop. And on top of, for the website, again, I think putting the hospitals that are recognized up on a website, those hospitals have elected to enter into this program. So NEDARC didn't feel that that would be any type of conflict in terms of confidentiality, but I'd love to hear other people's thoughts on that.
Perfect. And so just, I guess you could potentially assume that it's a voluntary choice to share their score on behalf of their hospital to participate in this program. One of the considerations that was brought up, in the chat box and some of the other pieces is, is there a need for a hospital administrator to agree to participate in the pediatric recognition process? And this has come up in some places of like, how do we know we can share a score? Is it important if it's the person who took it? Can they participate? And this is where I think the verification piece comes in really important, is that it's an opportunity to bring in all of the hospital leadership to make sure that they're on board with the pediatric readiness recognition process as well. And that it's not simply just a score based on one person at the institution who's interested, but it actually represents a larger culture shift across the institution. And then Hillary, there was a question that came up about inpatient resources and stabilization in the ED. Do you want to talk
Sure.
about?
So this is something we've looked at. It's a little late on the 2013 data, but one of my fellows, as well as Dr. Remick and myself, looked at some of this data about the inpatient capability. And we do know that having increasing pediatric inpatient capability is tied with higher readiness scores, and that's not surprising. If you have a PICU, you probably have increased pediatric resources at your facility. However, we don't have, as far as I know, we don't have the data yet to link that to clinical outcomes. Correct me if I'm wrong, you guys, but I think that what we know from the studies that are going to be presented in a minute is it truly is that initial care, the index ED visit, that seems to be linked to long-term outcome. People like Dr. Newgard have looked a year out, and it seems to be that index ED visit that's linked to things like mortality long-term. So even having a fully capable hospital with NICU, PICU, PEDS ward does not overrun the necessity of having a ready PEDS ED.
Perfect. So just in summary is that inpatient capabilities are different than ED stabilization. ED stabilization is critical, and Dr. Newgard has shown that through his work. And then when it comes to confidentiality, sites can certainly voluntarily submit their scores. And in fact, all of the EMSC state partnership managers on this call know that they have the scores of every site in their state. They're just not permitted to share those publicly. So any site that participates in the PEDS Ready assessment can certainly share their score with the EMSC state partnership manager. In fact, that already has been shared. But it's a question of, do they have the buy-in of their site to participate? And that's where it can be really helpful to just make sure that you're not sharing anything publicly unless the whole site is, willing to allow for that. So thanks for that. And then next slide. So the last question is really related to verification. And you kind of alluded to this already, Hillary, but a lot of states have been talking about how it's such a heavy lift to actually go on site and verify facilities. And if PR scores are already associated with decreased mortality, isn't that sufficient? Is verification really necessary? And then do you know of ways to decrease the cost and effort associated with verification? And I'm happy to chime in with what we do in Texas too.
Yeah, and so this is probably the hardest part to answer and to rectify. And I don't think there's a one size fits all answer to this either. I will, I looked up the old quote, trust but verify, and it was given by Suzanne Massey. Some of you probably know this, I didn't know this, who was an advisor to President Ronald Reagan. And it really came with the talks with Russia. And the thought was that a responsible person always verifies everything before committing, even if that person is totally trustworthy. And so I think that's a good concept with this. Again, these scores are self-reported, and we trust our ED nurse managers or our medical directors or whoever filled out this assessment that they did their best effort to answer things truthfully. We trust that that is the case. However, I can only speak for Utah, but when I look at our Utah data, I see the scores of some hospitals compared to scores of other hospitals I work closely with. And I see some hospitals scoring higher than hospitals I feel are extremely good at taking care of children. And so the score is just one component of pediatric readiness, and it does not, like Kate said, according to what you answered, one hospital might have PECs and they might have a quality improvement process, and they might have some key policies that we think are very important, but maybe they're missing a few other things, versus another hospital doesn't have a nurse PEC and doesn't have a quality improvement process, but scores higher. And so when we look at maybe what is the most critical out of the assessment, we believe that all components are important for that baseline readiness, but they're not perhaps all weighted equally. And so we need a way to also go in and figure out, and it can be, maybe, I know Dr. Auerbach had mentioned it, and where he works, some of the hospitals do peer reviews of each other, or, different hospitals will go and kind of review each other is what I understood. And Mark, you can come in a second and tell me what I'm saying wrong about that. But I think there has to be some process, whether it's a pre-site visit where you fill out a little document, or does in smaller states, it's probably more feasible to have maybe your EMSC manager go and actually meet with some of those hospitals, or is it part of the trauma verification program? I think there's a lot of different ways to do this and ways to do it more cheaply. But I think there has to be, if you're going to use that score as a high part of your readiness index for recognition, there probably needs to be some way to verify that information. And
I think this goes back to kind of putting those, if there's going to be some kind of signage or decal or formal recognition, this goes back to kind of what is the expectation from families when they see those signs? How do they interpret that? And how are we holding not only ourselves, but the sites accountable to having what we think they have? But there are important ways to create efficiency. And Mark, I'd love if you would maybe speak to kind of what you guys have done in Connecticut for a bit. Yeah,
I'm happy to. I actually have a little bit on it in my slides, so I can come back to it at that point. But I did want to highlight, maybe I don't know if it's devil's advocate, but a different perspective that brings back some of the things you brought up earlier, Kate, which this is journey. So I think that, you know, thinking about a phased approach to implementation would be something that I'll come back to. And whether or not verification and the sophistication and the degree of verification that happens in the first iteration is the same as hopefully the second or fifth that are more robust. I guess I just wanted to sort of bring up that frame that this is a journey, and certainly within our process in Connecticut, there was a lot of concerns about being perceived like JCO, and in working with our stakeholders, it was a non-starter to begin with verification and that on-site piece. So we took an approach of we're going to start and try to raise the level of everyone each cycle, and I'll come back and speak more to that. But I think that verifications is a wonderful goal for a program and some element of verification. I do not think that you can have the voluntary report that was submitted as part of the project be a surrogate, but things that we've used, and I think what Hillary is alluding to, is when we're on site working together with that person, asking them to see some of the resources. But we did have a lot of pushback and concern about being perceived as a group that was there to judge them in the way I understand that we are judging them, as opposed to support them improving.
Thanks for that comment, Mark. I think this is really important. Just going back to the slides on, you know, our first step is really to expand our influence and expand engagement. And if, you know, there are certain terms or words like verification that might throw off your entire project. And so being really careful about what the culture is within your state and just trying to get your foot in the door. The way that we have addressed this in Texas was really to just get consensus around the concept of pediatric readiness before trying to specify criteria. The way this has worked in other states like Florida is we're starting with education and trying to just promote educational initiatives across the state related to pediatric readiness to grow awareness and engagement. So not everybody is ready to just launch a robust program from the get-go.
Yeah, and I just want to be clear that it's really important to let people know that this is evolving. So it wouldn't be fair to them to say, these are the criteria, and then come back in 2 or 3 years and say, we've raised the floor now. So I think that it was really exciting to us to hear from these same individuals that were worried about verification, to hear from them, well, we want to raise the floor and the ceiling and keep advancing this and looking back at this again every 3 years. I think some of the challenges, the amount of turnover. So it might be problematic. People might say, well, we thought the criteria was this, why are you changing it on us? But I think going for the sort of more mature program to start off, at least in our state, would have been a non-starter.
Just a couple other comments about that is we know among trauma, stroke, and STEMI centers that their criteria have changed over time. So there is a very strategic cadence to when that occurs. And so to Mark's point, if you're changing the criteria every year, probably too frequent, but maybe working with your key stakeholders to say, okay, now there's more evidence, in 3 years, we're going to raise the bar. So there are ways to kind of gradually move into that. The other piece I just wanted to speak to a little bit is efficiency around this, and also the term verification. So when we talk about a verification process here in this particular slide, we're talking about the EMSC Advisory Council or the EMSC program verifying the components. There's also this concept of verification at the state or territory level, which is more formal. Which is a more formal verification that would lead ultimately to perhaps designation. That's not what we're talking about here. So just to be clear on that, but ways that verification have occurred sometimes is through an application at the beginning, and American College of Surgeons, STEMI and trauma centers do this at the get-go, is that you fill out an application first that has a lot of the information related to the components that you're looking for. And that is a great way to decrease the amount of time that actually needs to be spent with the on-site team. The other way that this has been done is once that application has been submitted, reviewed, documents have been uploaded, processed, whether it's related to like competencies of staff or education programs, things like that, policies, procedures, then it shortens the actual verification. So that sometimes this can be shortened to a 2, 3, maybe 4 hour visit at most, where you have the the ability to ask specific targeted questions of things that didn't quite make sense in the application, but doesn't require, a 2-day full on-site visit with travel. All right, so with that, I'm going to turn it over to Mark and Corey to review some of the evidence behind where we are today.
Fantastic. If you go back one slide just for a second, and actually, Mark,
Lisa, I don't know if these are the updated slides.
yeah, they're not the updated
You mind?
ones. Or so, Mark, do you want to share if she just stopped sharing?
You can share or I can move yours over, the updated ones you sent to me. Either way.
Yeah, I could share. Give me 1 second.
Okay.
I'll come up.
I'll stop
Yeah,
my
and while
share.
he's doing that, I'd just like to introduce myself to y'all. I've heard your names and heard about the amazing work you guys are doing in your state, but I'm one of the EIC exec members maybe that doesn't get as much FaceTime with the state partnership managers and y'all. And so I'm Corey Chumpitazi. I'm at Baylor College of Medicine, Texas Children's Hospital, where I've been really involved with the knowledge management domain as far as that evidence synthesis as we develop our guidelines and toolkits with Dr. Auerbach and Sayedajad, but then also from the research domain. So with Dr. Stanley. And so I started out as a more clinical scientist, and I was looking at, I started out doing head-to-head, blinded clinical trials and those kind of things. So really thinking about that highest level of evidence to support the work we're doing. So, and then you guys know Dr. Auerbach, the man, the myth, the legend.
Good to see everyone. All right. So hopefully in this short panel, what we'll do, and please keep the questions coming if people have any, but we wanted some learning objectives. So we hope that after this panel, you'll be able to appraise the quality of evidence of different research designs. So this element of level of evidence, which Corey will highlight, then summarize the evidence of 3 key pediatric readiness studies. There's over 60 studies that have been published to date, and certainly that's just thrilling and exciting, but sometimes can be overwhelming. And then I think our stretch goal, but I really hope we can achieve it. So maybe I'll say begin to integrate involving research evidence into your facility recognition program.
And so when I think about those, I really think about what are the goals and the importance of trying to do this. And so we really want to talk about what are those high quality studies and where are the gaps and what do we need to do next? What data do we need to look at to try to get more information? And then what is that level of evidence? So we're going to spend a little bit of time talking about that so that you all have the most up-to-date information to really influence your states. So when we make evidence-based decisions, we really got to look at that evidence. What's the gap? So do the research that's relevant to the clinical practice, and we're going to look at 3 of those studies. And then hunting, make sure that you all have access to the knowledge you need. So how might you establish that literature search and look at the evidence? And we'd love to help you with that from a research domain too. If there are things you're having trouble finding or that we're definitely happy to look at those, but then we really want to look at the high quality evidence. So, we learn a lot from each other and we can see what is working well in states, but I'm in Texas with Kate and something in our state might not work in a smaller state. And so how can we find the evidence that's going to apply to you? And then really then get the studies out there to produce that gap. And that's where I really appreciate Dr. Hughes and Dr. Remick working on getting these studies out and helping to change, and the TI grants like Dr. Newgard. So there's a bunch of tools to help you find that information. I'm not going to go through those here, but just as a point of reference, how can we search those databases to find those studies? And then we're accountable too. We're trying to keep our research page up to date with the various studies, the PCARN studies, all of the EMSC studies to be able to help support your work. And then we'll talk a little bit about that knowledge pyramid next. So when we talk about those case series and those case reports, kind of like in my state, this worked well, we did this, we rolled it out to 8 agencies or whatever it might be. If we start looking at that towards that bottom of that pyramid is really starting to put those cases together after expert opinion. So we don't want to just convene the experts and say, hey, this is what we think. I think all of our ambulances should be green, or whatever it might be. We really want to look to the evidence of how is that going to change care. So then we start to put together those case series. We start to do those case control studies. So how do we match it against implemented in a time series fashion or implemented in different agencies in a region, so that we can see what really made the difference? And did just providing the education make the difference, or was it really the protocols and those types of things? But we start to build a little bit stronger evidence. And then we start to look at cohort studies where we can look at those different groups. And then we get down to where we really randomize things. And that's something that we don't really do as much in the state partnership space. I don't know, Mark, if you can think of any, or Kate, Hillary, really randomized control trials from a state partnership standpoint. Clearly from like pre-hospital medication and implementation, we have a lot of those, and we have some going on with different dosages for intranasal medications for seizures, or different routes of seizure medications. So that's where we kind of think about those studies against each other. And then even that higher level is if you do a bunch of those individual studies, then how do they compare against each other in a systematic review, and then those meta-analysis. So all ways of thinking about how is our evidence conducted, what studies do we need to have stronger evidence so that we can really advocate for change.
Yeah, Corey, a couple comments on that. Thank you so much. So while we don't have RCTs, and there's certainly areas of research, and I would describe what I like to call programs of research and the evolution of a program of research, which pediatricians, we talk a lot about growth and development. Really, if I look back at Marianne Gaucher-Hill's initial work, it was very much toward the bottom of case series and her expert opinion with Kate and others involved. And then a lot of the work now that is much more robust is cohort studies, and mostly retrospective cohort studies that I'll speak to. I don't know if we will get to more sophisticated designs like randomized controlled trials, but in other areas of research, that does usually come later. And the challenge is it requires a lot more funding to implement, to sort of say, okay, we're going to, have some states be randomized to this type of facility recognition or level or outcome, and some states randomized to others. These top two elements here are an area that perhaps we will go in the next number of years as the number of studies grow, which it has in our fields now that we're getting to 60 plus. You can start to actually blend those studies and make more powerful findings by saying, okay, there's now been, one study. It's hard to combine that with 2 or 3 other studies, but once you're getting up to 50 or 60, and then the real flag that I want to put in the road here is with the second set of pediatric readiness data that'll come in the survey next year. I think there's a really great opportunity to move us up even in the quality of those cohort studies, because even within each of these elements, the lower level cohort studies are much smaller in size and might not have things like patient outcomes. Where we've gone in the past 3 to 5 years, which is amazing, is moved into actually connecting the databases from pediatric readiness with things related to patient outcomes, which I'll speak to in a moment. So the steps in developing an evidence-based practice, I think we want to frame our question, gather the evidence, assess the evidence, make a decision based on that. And I think here we're talking about making a decision for our facility recognition program. At other times where we might make a decision about, do we want to try drug X or drug Y? But I think a critical element that I want to put here, and we talk a lot about PDSA cycles and iterations in our work in state partnerships and in pediatric readiness, is that you need to evaluate the evidence as new research is published or your question changes. So now that we're working together with trauma as an example, as part of trauma verification, and perhaps in the future as things evolve with this interplay between trauma and medical readiness, and then these new studies are coming out, we need to regroup, reframe our question, and potentially reframe our programs. So, searching is an essential finding. Medline is one way of doing this. We do have many of these searches already published on the NEDARC and or the EIC site. And I think that where these searches should help us as we get to the PubMed searches and the evidence is all along these developmental milestones when we talk about phases implementation. But where I think we need to be much richer in the evidence that we have is as we move to the higher levels of implementation, and particularly as we move over time. So if you're in the early phases, as I was mentioning for our first iteration in Connecticut, you might learn from other states what worked for them and actually might not work for you. So I remember hearing about Evelyn's program in Illinois and EDAP in California, and coming back to our state with that and hearing very strongly that was not going to work for Connecticut, and we needed to adapt and come up with program characteristics based on the evidence at that time. So the clinical questions that we put out there back when we first did this as part of the collaborative, but then again, we need to put out again with 10 years or 8 years of evidence since then is, do facility recognition programs improve patient outcomes? And is there evidence to support that? And then specifically, what factors are associated with improvement in outcomes can be used to perform your program? So we mentioned cut points and the raw score, but then another method that Kate mentioned and Hillary mentioned is actually diving a little bit deeper. So if you're asking for a policy, procedure, or guideline, actually having them share that document and show you how they're iteratively working on that. If they say they're collecting quality improvement data, have them share that data with you. And as Kate mentioned, that's a way of actually having things ready to go when you come on for the visit. So if you search pediatric readiness, very exciting. I'm not sure where this was a year ago. It probably was less than 50, so a lot within the last year, but now there's over 60 articles. Many of those in the last year related to pre-hospital readiness, but hospital and pre-hospital readiness. This is what many of us will use, something called PubMed to search. We do have that search automatically available for you on the EIC and NEDARC website. So just looking at the evolution of data, I think that there's two buckets I wanted to put this in. One is the evidence for pediatric readiness and facility verification, and Kate set me up there this before with some of her prior work in California. And the other is related to cut readiness and facility verification. There's two studies that I just wanted to highlight. One by Kate and her team going back in time in Annals of Emergency Medicine in 2016, showing that verified EDs, when they did on-site verification in California related to their EDAP program, they had higher readiness scores and it moved the needle. So being measured moved the needle was sort of my takeaway from that. I don't know, Kate, if you have other comments on that pediatric readiness verification study which really predated a lot of this facility recognition collaborative work.
I think you covered it, Mark.
Okay, thanks.
Yeah.
And then a follow-up study, which Travis Whitfield, who's in my team here at Yale, and many from NEDARC as well as HRSA collaborated on looking at how do states that have facility recognition programs, demonstrate that those recognition programs are improving readiness. So retrospectively, the data was extracted from 2013, which is something you're going to hear as a common theme here, that almost all of this data was basically the NEDARC data set from 2013 being overlaid with other data sets. So this concept of meshing of data sets is something that's going to come up as a theme for all this research. But this work noted that those states that had a recognition program on reporting to HRSA had a 9.1 higher pediatric readiness score. But more importantly, and this was all recognition programs, some based on score, some based on other factors, that states that had a recognition program and then the hospitals that had been recognized compared to hospitals that were not recognized had a 21-point higher PRS score, which is really, I think, really great to see that there is a correlation there. So looking at this evolution of sort of what I would say is the top 5 pediatric readiness articles, I think there's the most groundbreaking and important of the articles that was really just description of pediatric readiness based on the 2013 data by Marianne and others that was eventually published in 2015. This was the national assessment. Then another very important study that shows some of the geographic variability in pediatric readiness was done by Dr. Ray. Then I'll speak to these two studies about mortality, one medical and one trauma by Dr. Newgard, and then briefly comment on the more recent study by Dr. Newgard about mortality over time. I did mention 65 studies. I'm only listing 5, so I'd encourage you to consider just popping in pediatric readiness into PubMed or going to our site. But other clinical topic areas that HRSA and many others on this call have look at things like the overlay of readiness or recognition programs in critical access rural hospitals using simulation, other parts of the world, like a study that was in Latvia looking at health systems level changes. And exciting to say that more research is in the pipeline, and work by Hillary, by Dr. Remick, by Dr. Hughes, by Dr. Newgard, and many others as a part of this pediatric readiness study group that is actually funded, and really the funding is something that's critical critically important to move up that pyramid is going to continue to evolve over time. So I would expect a lot more studies. I wouldn't be surprised if when we have this meeting, if we do again in a year, that we'd be close to 80 or 100 studies. So one of the challenges with all these studies is they are retrospective cohort studies or self-report. So the first study, which was self-report, as Hillary mentioned, but was a phenomenal project looking at over 4,000 EDs. And I know that we've all seen this slide before, but this was a descriptive study, really the Pediatric Readiness Project from 2013, and demonstrated one of the key takeaways to me was that volume correlates with pediatric readiness score, and that overall there were opportunities for improvement. Really the 2013 survey and these data were critically important to guide the future work. So what Dr. Ray did was try to look at access to pediatric ready hospitals in US EDs. And with Dr. Ray's work, as well as Dr. Newgard's work and Dr. Ames's work, I wanted to give the caveat that all of these are reliant on secondary databases. So they're not taking all 4,100 EDs, they're often taking slices of that. What Dr. Ray did that was really brilliant, and Dr. Newgard is doing now, is actually overlaying census and other geospatial data to look at where kids live and understand how people can access care. Because when we have an emergency, we know that the access to care and how people make those decisions might be a bit different than if their child had cancer and they have time to Google and research. So the goal of that study was to determine the geographic accessibility of EDs with high readiness by assessing within a 30-minute drive time to those EDs. And it was cross-sectional. I know this sounds very fancy, but a geospatial analysis, I'm going to show you on the next slide what that is, but trying to get at where these hospitals are located and can families get there even if they knew that they're ready. And I'd like to recognize Dr. Ray for creating these slides. I don't want to take credit for that, but she located the EDs, then she located high pediatric readiness EDs and looked at how far away those EDs were from each other, and then looked at where people lived and tried to understand if people lived both close to a pediatric ready ED and a non-ready ED, and or closer to one or the other, to understand where children may present for care. So access, I tried to summarize this here for you in this graphic. I'll come back to this in a moment, but really people can live close to both EDs when they're in urban settings. So I can say that this is the case where I live. My closest ED, which is about a mile away, is not pediatric ready. My pediatric ED where I work and a couple other EDs in my area that are 2 to 5 miles away are very pediatric ready. And my neighbors and friends might not have that understanding when they're trying to access care, and oftentimes will go to the closest ED. The cut points, apologies for the typo there, for pediatric readiness scores really vary between these studies. And I just wanted to really highlight that. And I think Hillary mentioned this, and it's so important because when we talk about high pediatric ready, some of us will interpret that as being ready 100%. So you are ready if you have 100 on the pediatric readiness score. Others will interpret that as being in the highest quartile or percentile, and I'll come back to that. So having a single cut point is challenging, and this is what Craig and some others have done in their work, to take that cut point and put it at all EDs. But the 100% cut point I actually am pretty comfortable with. So if you have 100%, I think it's reasonable to say that you're pediatric ready. What she did in this work was actually then looked at the 90th and 75th percentile. All of these scores are quite high compared to some other scores that have determined pediatric readiness, particularly if we look at Marianne's work where the national average was 70%. And then she also looked at subscores. So looking at that data, I think I just put this graphically because Stephanie's slide, Dr. Ray's slide was a little difficult to understand for me. So I just wanted to highlight 94% of people live less than 30 minutes from a pediatric ready ED. So many people will be like, awesome. Most of the country lives near a pediatric ready ED, a place that's close to 100%. So that ED is near their house. Unfortunately, about a third of them live less than, only about a third of people, their closest ED happens to be pediatric ready. So 90% or the majority of the population will actually live in a place where the closest ED to them is non-pediatric ready. this is a difficult construct to understand. That's why I like to show it with a figure here. So in this figure, if that patient, that mom and that baby live closest to this hospital that's not pediatric ready, even though there's another pediatric ready ED, perhaps one of the top EDs in the world right near their house, they are most likely to access care from everything we know at the ED closest to where they live, whether that's with EMS or with their parents taking them. And improving pediatric readiness within the existing EDs, which I think is the exciting point of this, could take the closest ED up from 33% up to 94%. And that's, I think, to me, looking at this was a critical way of getting behind, okay, this matters in my neighborhood because we can improve access. So this is sort of mirroring that, but looking at the different cut points here. So if we use 100 as a cut point versus 90 or versus 75, as we expand that, EDs with the pediatric readiness is closest to them becomes larger. So if we use a cut point of 75%, more people live closest to one of those EDs. So I'm going to skip ahead here to just for time's sake, and happy to
Mark,
share.
just if I could just ask a quick question then. So what is your takeaway knowing the disparities that exist when folks are thinking about their facility recognition programs or PEDS ready recognition programs?
Yeah, my takeaway from the first study would be that looking at the cut points are really critical, and looking at not only cut points for the EDs across the state, but based on where children live as well. Because I think that if we want to, my vision of the ideal program would somehow ensure that all children had access to a pediatric ready institution within 30 minutes of where they live, and it was clear to them which institution that was, because there may be states where every institution wants to take care of as many children as possible. There may be other states where some institutions, frankly, would prefer those children are going to a different hospital. So my takeaway would be looking for programs, and I think the EDAP program in California did this in some ways, where you're going to create levers that if people are willing to put themselves out there as being pediatric ready and put the resources in, making sure the families are aware of that as they make decisions about where to go for their emergency care. I don't know if others have comments on that. It's a challenging topic to think about the geospatial piece, but I think it's critically important because of the fact that this is so different across the country.
Well, and then if I could just make one other comment about that, if we're thinking about the, the fact that the majority of children live in rural and remote areas, how does that translate with this study?
Yeah, that's a great question. I think that the rural and remote areas can be more difficult to measure, and the data is less available oftentimes in those places, particularly in the number of children. So I think we need more work. There's some great work on overall readiness in rural and critical access hospitals if you do that PubMed search, but overlaying rural and critical hospitals data is very hard from a research perspective because there's very few total children, is at least my lens. I'm not sure if others want to give a different frame on that, but I think it's challenging. And actually, it's a nice segue to this, Kate. So if we look at Stephanie Ames's paper where she looked at pediatric readiness and mortality, I think one of the challenges is with the low number of children presenting to many of those rural EDs, taking these data, which basically what Stephanie did was she did a retrospective study. She took all the data from the NEDARC group for the Pediatric Readiness Project, and then was able to take data that was available, not that she decided to study these states, but there's a federal program that called HCUP that has data on EDs available in the National Emergency Department data set from a variety of states that submit that data. New York, Nebraska, Iowa, Florida, Massachusetts are who she used, and overlay those two data points. So we are missing many rural states. We have some rurality in some of these states. She did some fancy statistics. Again, I'm not aiming to have you leave here understanding logistical regression and fractional polynomials, but basically did fancy statistics to adjust for things like the severity of illness, the frequency of presentation, and was able to take out 20,000 children presenting to 426 hospitals. Those hospitals had a slightly higher readiness score than the national average of 69 plus P4, so it's 75 here for her cohort of hospitals, and found that hospitals with lower scores, again, were often lower volume, and that children presenting to hospitals with lower readiness were older and often had fewer complex conditions. but really powerful data, which to me has entered my elevator pitch now anytime I'm talking about any of the work we do, but did not exist when we created our criteria in Connecticut, is that she was able to demonstrate a fourfold unadjusted improvement in mortality looking at these scores. So if you presented to a hospital in one of those states and your hospital had a score above 88, that you had a percent mortality of 3. If your hospital presented to a hospital that had a score less than 60, your mortality was 11. Again, it's really important to show here that if we look at the different cut points, 3.4 only goes up to 4.9. The dramatic effect seems to be at some of the lowest levels. And what the top numbers there are what we call the adjusted ratios. These are putting all those other fudge factors in to actually look at how things like chronic disease and other aspects affected care. This again is some of the data that I think because of time I'm going to skip through, but what I wanted to highlight, and I don't know if Hillary or Kate want to comment on this, or Corey, this comes up in this slide deck as well as in Craig's slide deck. And I think this shows you that we have to take all data and think about the clinical implications. So if you look at this and we look at mortality and pediatric readiness, the adjusted mortality tends to go up and down. And this fact that there's this weird sort of mortality, as scores go up in this lower segment, go up and then go down after that is counterintuitive. And it could be a problem with data collection. It could be some unknown thing that we don't understand about how kids are cared for. But it is interesting that we do see this sort of inverse relationship in part of the pediatric readiness score and mortality relationship in both trauma and medical care. I'm not sure, Kate or Hillary, if you guys have comments on that, but to me, this gets at the real important construct of saying we can't necessarily say a score is perfectly representative of quality of care or of pediatric readiness.
I think it's likely reflects the fact that most of these sites don't have a single death because their numbers are so low. So we're just not able to really capture an appropriate adjusted mortality for those sites.
I also think it also represents that, again, the score is just one piece of data and it needs to be tied to a bigger picture.
Yeah.
I think that's why also, if you go back, you see the range.
Yep.
Confidence intervals are so much higher at those low readiness scores because there's so few facilities and they tend to have very low volumes.
Thanks, Kate.
And I think about your point about the rural hospitals too, Kate, is something that really could look at too, because you said, sure, if they went to a hospital within X amount of time, but if there wasn't another hospital, how are those scores in those rural areas? Yeah. And I think a lot of the times, this data doesn't get quite down into that. And I think a really important population to evaluate.
Yeah, and also many more EDs in the highest quartile than the lowest quartile. So just wanted to flag this for the group that exciting to see that based on many of your great work that the many EDs were in the highest quartile of pediatric readiness. But remembering in her study, the highest quartile was not 100% as Hillary got to. It was the highest quarter of scores. So the conclusions from that paper that I took away is patients with critical illness, presentations to hospitals with high readiness is associated with mortality in a large data set of a limited number of states, and that our efforts hopefully are supporting our efforts to improve readiness and improve outcomes, but that again, as I mentioned, it might not be enough as a standalone. Craig Newgard's work, just to highlight here, what he did was layer in 372,000 visits to US trauma centers that had pediatric readiness scores and tried to look at mortality and outcomes. The numbers are listed there. Again, thank you to Craig for sharing some of these slides. He also broke this down by quartiles or percentiles. So if you look here, his percentiles came out because they're different cohorts. So the hospitals included in Craig's data were trauma centers. The hospital is included in the prior studies were different hospitals, both a mix of trauma and non-trauma centers. So for Craig's data, the median ED volume is listed there, as well as so again, seeing this volume pediatric readiness score relationship on this graph, whereas higher volume hospitals appear to have higher readiness scores, but the overall trauma center pediatric readiness scores appears to be higher than the cohort that we listed on the last slide. And when Craig breaks this down, he's able to look at survival and how this in-hospital and out-of-hospital survival impact are impacted by readiness score. And in that highest quartile, if we were to interpret this as I tried to do for the work on medical, we could say you have approximately half the likelihood of mortality if you're presenting to a highest quartile pediatric readiness hospital, which is a very compelling argument to improve readiness from a trauma center perspective. If we look at Craig's data, he again had some of the same challenges where the weighted pediatric readiness score and the predicted probability of mortality seemed to sort of be counterintuitive by going up with increasing readiness score. And I think we addressed that on a prior slide. And I think I'm going to just very briefly mention, if we look at Craig's most recent data and death after presentation to a trauma center, one of the things that we see on here is that the fourth quartile does stand out and the third quartile stands out, but that first and second quartile are really close to each other. So just using these cut points as a sole distinguisher can be a little bit challenging. So limitations to this research: the data is retrospective, it's self-reported. The data in the NEDS data set and the trauma registry data set are self-reported. They're a little bit more robust because they're reported by researchers and trauma centers than the self-reported data for the pediatric readiness survey. I would say that some of this data is now starting to be old, and we can say that because we have new data coming out this year, but we're getting close to a decade. And the data that was available was limited. So there's a limited number of states in some data sets, a limited number of trauma in others, and that this is a understanding of readiness related to mortality. So a really small subslice of the patients we're seeing. Most patients, fortunately, do not die. And it's hard to walk back this mortality data to everyday readiness for lower acuity conditions and potentially non-mortality inducing conditions. So I just wanted to bring up, I pulled up my Connecticut slides. So our slides for our Connecticut SBAR when we went out in 2016 really had data on where kids presented and the importance of readiness. So we sort of had this SBAR pitch that we pushed out to all the sites, but did not necessarily have data to support mortality. So I wanted to demonstrate, we started this work in Connecticut in 2016. Our plan was to iteratively adapt, which we did up to through 2017. And then after our implementation, we have now a new team. I am no longer the medical director. Vicky is no longer the program manager. So now we need to make sure that that team understands and with the handover reevaluates the evidence and hopefully continues what was our plan to raise the floor after enrolling our additional cohort of hospitals. Our model in Connecticut was to try to have a all teach, all learn and get everyone to show up and engage in some way. I need to create this slide now with the elevator pitch. I actually intentionally left that blank together with our EMSC team of what's our new elevator pitch with this new data. But I did want to highlight that our work before, we struggled a lot with semantics and what we really, whether or not we should have used pediatric ready here, I think gets back to some of Kate's comments and how we communicate that to the public. But in order to include everyone, we did have this term pediatric engaged, where as long as you had what at that time was the strongest evidence, a pediatric emergency care coordinator, physician or nurse, and senior leadership buy-in, we wanted something to say you're showing up to the table and you want to participate. And at that point, our cut points were really based on a national average. That's really all we had. And now that we have more than a national average, we hope we can advance that over time. And this is one way of doing this work. I don't want to say that is the right way. It potentially has many flaws, but in Connecticut, it worked best for our state at that time. But again, I think in reflecting for this discussion, one of the concerns that I have is with the turnover, our initial vision and many of these concepts that we had when we started this of let's get everyone to the table and then we can hopefully move the needle forward, that could be lost as we transition between programs and leadership and with the evolution of research. So we need to continue to bring back that research and hopefully continue to move both what I would call the floor, so the lowest level of readiness in that engaged group, as well as the ceiling, the highest level of readiness. If you're 100%, we still want you to be sharing with others and helping to improve everyday care for all the children in our state. And thanks so much for the opportunity to share.
Guys, that was awesome and so helpful, I think, just for everyone to hear some of the evidence behind how these we think about developing these programs. Given that it's already 1:15 and or Central Time, and we We'll end around 1:30. I think at this point, we can open it up for just questions more broadly. I think, again, really, really critical information for everyone to understand as you're thinking about the criteria and also talking with your EMS advisory committees about this work. So any comments, other comments or questions? And hopefully we've addressed everything in the chat so far. Okay.
I guess I'm going to put a question out there, Kate. So the states that at this point are at the not lower level, the earlier stages of growth and development. So stage, 1, 2, or 3. I'm curious if, as you've restarted these discussions post-COVID, how those discussions and those elevator pitches have happening, because I don't envy my team in Connecticut having to circle back around this with this post-COVID, where there's many of our EDs almost 100% turnover and a overall sort of very different frame in the work. So I'd love to hear if people are entering that again, so I can give some guidance to my team here, because COVID took a lot out of us.
Comments from anyone around that? Dwayne, go for it.
So, challenges, and I'll just kind of summarize them. Yes, new people, new contacts. The last year's survey was helpful in getting and verifying some new contacts, but taking those numbers and reaching out to those respondents for some clarification has been less than responsive. So, via email. So it's taking time and effort to have that engagement, building that relationship, like you said, but keeping on top of it, so as those contacts might adjust because of movement, that you can keep on top of that. Engagement from kind of the leadership stakeholders, those statewide organizations, whether they be governmental or industry, has been variable. Some doubters that this is something that can be done because of all the challenges of COVID and everything else, too many other higher priorities, and trying to educate those leaders of the importance, and just the amount of time available to do it is the other challenge. At least at my part in trying to promote this in order to get a large group together to be able to then champion it as a group versus an individual.
Thanks, Dwayne. I'm curious, in those follow-up discussions, have you been able to layer in the trauma process? And if so, has that served as a lever for these places, bringing up the ACS piece of this? Because to me, it seems like a very nice lever to have that we didn't have before.
So yes and no. In Pennsylvania, we're not an ACS state, but the Trauma Systems Foundation oversight and their leadership is on board with this, and we have already identified some of the pediatric readiness components within the current trauma standards. But the language that got added to ACS we haven't had a conversation between EMSC and the Trauma System Foundation yet, but I know it will be in the short future in order to do that. And discuss whether there's going to be any language changes to their accreditation standards that would reflect that ACS language. I just haven't had the conversation yet.
And we do plan, just for everyone's awareness, to talk a little bit about the new trauma verification standards and how that might intersect with your program during our next community of practice. But Sherry, you had a comment?
Yeah, thanks everyone. In West Virginia, I think the new guidelines from the college and bringing the trauma community into it is going to help us. We have what we call Always Ready for Kids recognition program. It's been around for a while. COVID really took a hit on us, but with the survey, and we brought the survey to our trauma advisory council. And it's been met with really good response. And even I've had calls to say, can we put pediatric readiness under the trauma hat? So at least in West Virginia, it's been very helpful for us. And we look forward to really some great discussions in the next 6 months.
Thanks for that, Sherry. And, you know, just for awareness, there are some efforts actually underway in the Great Lakes states around leveraging even some of what happened with COVID around disaster planning and thinking about how can you partner with healthcare coalitions or regional coalitions for disaster planning and really take this readiness effort to heart through that. I think just the important piece there is just making sure that EMSC remains at the table with a critical voice as the pediatric champions. Other thoughts or comments?
Yeah, I think Chelsea's comment is really important, that people are still picking up the pieces. So when and how is the best time, and we're happy to share these slides too, and happy to think through what kind of infographics or other items might be helpful for your states.
Great. So just we can probably finish up a little bit early. Obviously, we didn't have time for the breakouts today, but just as a reminder, what are the goals of this community of practice? It's really to grow and expand these programs, share best practices, and we'll continue to do that through breakouts. Remember that there are all those resources on the EIC website. If you search Facility Recognition Collaborative or past collaboratives, you'll find it there. And we will continue to create breakouts based on those phases of development. On the horizon, just for everyone's awareness, we are planning on launching another PEDS Ready Recognition Collaborative. It'll likely kick off in September of 2023. So if you didn't get to participate in the 2016 one, we hope that you'll be ready to join us for this one that'll be coming down the pike. And even if you did join the 2016 collaborative, this will be a little bit different because we know now there are a number of states that have EMS recognition programs. And so how do we begin to develop those two across the states? And then, as I just mentioned, at our next community of practice, we'll really be talking about this whole role of trauma systems, and especially with the new announcement through ACS, and there are now a number of states that are developing pediatric readiness criteria for lower level trauma centers like level 3 and 4. So what is the impact of that? Both the pros and cons. What do you need to watch out for? How do you really leverage that to help your program take off, as we go forward? So I think that's all we have. If you have any additional thoughts, suggestions, how we can do this better, please send those to us, and we'll stay on the line for the next 5 or so minutes so that we are here to answer any questions, and just appreciate everybody joining today. So thanks so much.